Stuff we use year-round in Houston. Air conditioning.
You guys getting some cool air back there?
Yep.
We use our grills.
All right, dinner's almost ready.
And yet we definitely always use our common sense.
Trying to make a program that would have common sense.
Common sense isn't so common.
No, it just makes so much sense.
So right now, join lifelong Houstonian Bill King as we take on the issues with a little bit of Houston common sense.
Common sense.
It's time for Common Sense.
This is Common Sense with Bill King. Here's Bill.
Good afternoon, everybody. This is Bill King, and you're listening to Common Sense. Thank you so much for joining us for this, our kickoff show. We're going to be meeting here every Saturday to discuss the critical issues that are facing our country, our state, and our region, and see if we can't bring a little common sense to the conversation. Today, we're discussing what's on everybody's mind, of course, the coronavirus. And my first guest is Dr. Peter Hotez. Dr. Hotez is the Dean of the National School of Tropical Medicine at Baylor College of Medicine, and he's the co-director of the Texas Children's Hospital Center for Vaccine Development. He is also the author of 3 books, including his most recent, Vaccines Did Not Cause Rachel's Autism, which is available on Amazon. Dr. Hotez, welcome to Common Sense.
Honored to kick off your show.
Thank you so much for joining us today. I want to get right into this. We've already got questions coming in, and everybody is anxious to hear what the experts have to say about this. I'd like to start with just getting your sense of where we are in this pandemic. There's been a lot of discussion about flattening the curve or whether that's happening or not. Will we have a second wave in the fall? What are you expecting based on the numbers you're seeing right now?
Well, right now the numbers are still pretty robust in the United States. COVID-19 is still on a daily basis. May not be the single leading cause of death anymore in America, but it's still maybe second or maybe second. So that's a real concern. And we've all seen the devastation in New York and New Jersey and the thousands of deaths there. And those numbers haven't really gone down all that much yet. Texas did a little bit better. We seem to have been, maybe because we implemented social distancing earlier on, we saw what was happening in New York and New Jersey. And then we did some pretty drastic things like shutting down South by Southwest and the Houston Rodeo. We know that caused a lot of pain, but I think it paid off. I think as a result, we've never seen that big peak like we saw in New York and New Jersey. So that's potentially good news. The not so good news is we are still seeing a fair number of cases in Texas and in Houston, even though the peak's not as high. The number of cases is not really going down all that much, and this leads to some questions about how safe is it to start reopening the economy at this point? So
one thing I'm curious about, we were talking about these waves of outbreaks, and we know that happened in the Spanish flu back in the 1918, 1919, and that's what we're talking about again. Can you explain to our listeners what's the mechanism behind these things seeming to have peaks and valleys?
Well, I really wish we knew. We don't really have a good understanding of seasonality. There are now some models from my colleagues at Harvard School of Public Health that find there may be another annual peak or wave of this virus every January, February. And just like we've seen with influenza in the past, why it is that we see that winter peak of either flu or COVID-19 is not clear. We know that this virus does not, and the same with the flu virus, does not do that well with direct sunlight or with high humidity, so they may have something to do with it. But then it doesn't explain why we have flu all year round in the tropics. So there's still a bit of a mystery. Some say that crowding and density is a big factor, and seasonality is second. So that in places like crowded cities in the tropics, even though it might ordinarily go down with this direct sunlight and warmer weather and higher humidity, the crowding still is dominant. So the current thinking. So what does all that mean for COVID-19? The current thinking is that there will be another peak of this virus in the winter months, The big question, though, is will there be another peak in between now and the winter, meaning that because we are relaxing social distancing before we've hit the bottom, the nadir in terms of the number of cases, will we see a new spike in the summer or in the fall, in the weeks and months leading up to the 2020 presidential election? And that's what I'm concerned about, because the models coming out of the University of Washington say that we really should continue social distancing aggressively to the middle of June. And now, of course, the governor has been opening it up sooner. And I understand those economic pressures. My son Dan works as a petroleum engineer, and he's watching those price oil, and it's devastating. So I understand opening it up, but the thing is, can we do it now in a way that does a public health response that's commensurate with the economic response, in a way to do it responsibly so we don't see that peak in the summer or the fall?
Yeah, so I think we've got 35 states now that have begun to ease restrictions to one degree or another, and so I'm taking it that you've got some anxiety around that. Specifically, what do you think about this sort of phased approach we're doing in Texas, where only 25% of capacity is allowed in retail and restaurants? Is that a reasonable way to sort of tip our toe into the water?
Well, unfortunately, this is a new virus, and we just don't have a lot of evidence to support it one way or the other in order to create a real roadmap. So, I understand the rationale behind it, and it's easy to throw stones at any plan because we don't have a lot of data, but I understand the basis of it. My only point is, look, if you're going to do this, at least have a public health system ready to go in case those numbers start to climb.
Right.
And that's been my issue is, there's a great economic recovery team in place that the governor's put in place, business leaders, everyone's trying to act responsibly. But, if you look at the big cities in Texas, and that's where we're going to most likely see COVID-19 return, if it does return, there's not really a system in place for instance, testing at the workplace, or if there's been hiring of contact tracers, it's just a fraction of what we need, or the syndromic surveillance or the communication. So if you look at the pieces that they've put in place, like the county judge has put in this system of, I think she calls it testing, tracing, and treatment, and that's absolutely fine, and she's absolutely right to do that, and I'm glad to see that. But the magnitude is too small. It's not. I worry it's not adequate for the fourth largest city in the United States, and I'm pretty sure that the same thing's probably going on in Dallas and San Antonio and Austin and Fort Worth as well, and that's where the risk is. That we're not investing sufficiently in public health to prevent that big resurgence in the summer or the fall.
Okay, we have to hold it right there. We've got to go pay some bills. If you'll hang on, we'll be right back with you in just a couple minutes, Doc. Hang on, everybody, to hear more of Dr. Peter Hotez and what he has to say about the coronavirus. Be right back. Hello, everybody. We're back with Common Sense. We're talking about the coronavirus with Dr. Peter Hotez from Baylor College of Medicine. Dr. Hotez, welcome back.
Thank you so much.
Let's talk about immunity and vaccines a little bit, because I know that's an area that you study very intently. The World Health Organization came out a week or so ago and sort of questioned whether someone would have immunity if they had the disease and developed antibodies. Some people like Dr. Fauci pushed back on that. Then the World Health Organization seemed to sort of backtrack on their comments a little bit. Can you tell us, if somebody gets sick and gets the antibodies, are they going to be immune? Are they going to have some level of protection?
I think what happened there, I'm not sure the WHO really came out and said there's no immunity. I think what happened was they just didn't feel comfortable yet issuing what they called immunity certificates, like they do sometimes with yellow fever and others, and maybe it was interpreted a little bit incorrectly. I mean, I think what happens with COVID-19 is probably similar to what happened with the first SARS epidemic back in 2003, a related virus, where people get infected, they get exposed to the virus, they develop an immune response and antibodies. And most of the time, those individuals are resistant to reinfection, at least for a period of years, until the antibody titers start to decline. And what that period of time is still a bit unknown. Probably between 2 and 10 years, you have that immunity, and maybe longer. And I think probably the same thing happens with COVID-19. And the reason we say that is there's been now some experimental studies in rhesus macaques, non-human primates, showing that if you give them COVID-19, they develop an antibody response, and then you can no longer reinfect them. So we don't know for certain, but there's a likelihood that antibody does confer protection. I think there is going to be a subset of people that with either low-grade symptoms or no symptoms may not get a vigorous antibody response, and they potentially could be subjected to reinfection. But I think for the majority of people, it's going to be the situation: you get infected, you develop an antibody, and then you're protected against reinfection. But we'll see over the coming weeks and months.
I mean, Doctor, are there viruses for which we do not develop immunity? Does that happen in the natural world?
Well, it certainly happens to some extent with HIV/AIDS, right? And that's why it's been so problematic, because you get infected with the virus, then you carry the virus typically for your whole life, and you don't develop immunity. But for most respiratory viruses, it's the case where you do develop immunity, and I think this will probably fall under that category.
Okay. Let's turn and talk about vaccines for a bit. I know you've been very cautious in your previous comments about the timeline for developing a vaccine. We've sort of had a deluge of media coverage here recently about particular vaccines like Johnson & Johnson and the Oxford University, where they're talking a lot more optimistic and aggressive timelines. What is your feeling? Are you more optimistic these days, or are you still pretty cautious about the timeline for developing a vaccine?
Well, Bill, over my whole life, I've developed vaccines for neglected diseases. So the fact that I'm developing vaccines for something called neglected means by definition I'm an optimist, and I am an optimist. I think we will have a vaccine, maybe several vaccines for this disease, and hopefully ours will be one of them. So we're working to get one of our vaccines into clinical trials by this summer. The thing that I've not been happy with is some of the inflated statements some of my colleagues have been making from either the biotech world or the pharma world, or in some cases other academic institutions, when they start promising they're going to have a vaccine within weeks. And the reason I push back on that is because, like ours, ours will go into clinical trials, theirs will go into clinical trials, but then you've got to see. You've got to take the time to make sure you have a vaccine that actually works. Just because you've shown it works in laboratory animals like we have doesn't mean at all that necessarily it'll work in people. And just because you have a vaccine that seems to be safe in laboratory animals doesn't mean that vaccine is going to be safe in people. And that takes a little bit of time to work out. And so usually takes years to accumulate all of the data showing that it works, and years to show that the vaccine is safe before you release it. Now we're going to try to compress it in as short a timeline as you can. But then, when they come out and hold a press conference, say, the vaccine's going to be ready in a year and we can all go dancing in the streets, I think that's irresponsible. It also plays into the hands of the anti-vaccine movement. In the United States now, we've got a very aggressive anti-vaccine movement, and they go after me a lot, and because I defend vaccines, and I have a daughter with autism, and I wrote a book called Vaccines Did Not Cause Rachel's Autism. And I wrote that to stand up to the anti-vaccine movement because that's one of their fake tenets, that vaccines cause autism. The other fake tenet is they claim vaccines are not adequately tested for safety, and we rush them. And that's not the case at all. We were very careful, and the FDA is very careful. So again, when my colleagues come out with statements saying we're going to have a vaccine in weeks or months, it plays right into their hands, and really gives them some good material to work with. So that's another reason I push back a lot against it.
So if you had a crystal ball, what would you say is the most likely time frame for a vaccine to be available to the public?
Well, I hate questions like that because I don't
put you on the spot.
The hope is, and whatever, one of the things about new virus pathogens is they set you up to make you look stupid. In fact, when I look at some of the things I've said about this virus back in January, I cringe. I say, "Oh my God, I can't believe I said that." I'm Dr. Fauci has charged us with doing this in a year to 18 months. We're working day and night to make that happen, and we're going to do our best to have it by next year. But we'll see. It all depends on how the clinical testing program goes.
Let me switch to a little bit different topic, and that's herd immunity. It's a term I think most of us had not heard before 6 months ago, and now we're all talking about it. Can you kind of explain what herd immunity is, and what does it really take to achieve that?
Herd immunity kind of refers to, if you look at a particular community, the percentage of people that have been exposed to the virus or been vaccinated, so they have an immune response to it, so that it actually interrupts transmission in the community. So we heard a lot this term about with measles last year when measles returned to the U.S. and especially in New York because of the anti-vaccine movement. That one, measles is one of the most contagious viruses known. So herd immunity means you have to have 95% of the population vaccinated in order to prevent transmission of the virus. With this one, we don't have a vaccine, but it's a pretty infectious agent. So the models say that 60 to 70% of the population has to be have an immune response, immunized against this virus, either because of natural infections or infection or a vaccine, in order to stop transmission. So that's where the number comes from. And of course, we're not anywhere close to that because we did the social distancing in order to save lives. The percentage of people infected who've been infected and recovered from COVID-19 in America is probably 10%, if that, maybe higher in places like New York where there's been a lot of transmission, maybe as high as 20%, maybe in Houston a little bit less, maybe 5 to 8%. So we're not even close to that at this point.
Okay. And I guess you're talking about those antibody tests that we've seen come out of New York and California that suggest there's a lot more cases than we've clinically or we've diagnosed with testing.
Yeah, absolutely. I mean, the testing says we have about 1 million cases in the U.S. I would say most likely it's at least, given all the problems we've had with testing, it's probably closer to 10 or 20 million, but that's still less than 10% of the U.S. population.
Okay, great. Okay, we're going to have to wrap it up here, unfortunately. I wish we had more time to talk to you. We're going to take a break now, but when we come back, we're going to be talking to Jeff Reichman of January Advisors about big data modeling and what that can tell us about the epidemics. Dr. Hotez, thank you so much for being with us today, and I actually ordered your book today about your daughter and looking forward to reading that. So thank you so much again for having us.
Well, I really appreciate it, Bill, and thanks for all your good work in the community.
Thanks. See you later.
Hey, folks.
We're back with Common Sense Talk Radio with Bill King. My guest for this half hour is Jeff Reichman. Jeff is a Houstonian. He's the founder and principal of January Advisors, which does data analytics for businesses, for government, and for nonprofits. Jeff, welcome to Common Sense.
Thank you so much, Bill. Appreciate it.
Listen, I think we need to – I want to get into the COVID stuff, but before that, I want a little bit of a groundwork here on this. We hear this term big data all the time, and I don't think any of us really understand, except you experts, what is meant by that. Can you kind of explain what the term big data means and the kinds of applications it can have?
For sure. So big data should really be called more data, because it's not that the data is any bigger other than file size and the amount of storage that you need. It's just that we have an immense amount of data about the world. And every time we implement a new technology system, every time there's a new app, every time there's something else technological in our worlds that's introduced, we collect even more data. And that's been growing like crazy over the last 20 to 30 years. And it's really reaching kind of an acceleration point over the last 5 to 10 years. And so this term big data is really an all-encompassing umbrella term designed to talk about the new tools and technologies we need to have and use in order to make sense of so much data that we have. It used to be you'd have an abacus, and that did the trick. And then you'd have, an accounting calculator, and that would do the trick. And then Excel did the trick. Well, we have so much more data now that we need more powerful technologies, relational databases, programming languages like R and Python, and scientific methods from all of these different disciplines to really make sense and derive insights from data today.
Well, and I guess also just the processing speed and capability and the degree that storage space, the cost that's come down so dramatically, all of that helps with analyzing these much bigger data sets.
Absolutely. It's really become commodified storage space. It used to be extremely expensive. It's less expensive now, but we need for our dollars.
Right. So can you give the listeners some examples of things that you have used big data, your company has used big data to analyze for your clients?
For sure. So most recently, we did some work around property tax protests and doing a study as to how homeowners fare when they protest on their own versus hiring help. We've done some work around disaster recovery and understanding the impact of Hurricane Harvey on the veterans population, for example, working with Combined Arms here in Houston to better understand how veterans are served and how veterans serve their communities after Hurricane Harvey. We look at things in the criminal justice system. We look at evictions and housing. We look at affordable housing. It really extends into all aspects of public policy. There can be a data-informed approach to better understand, what are we doing right now? How can we measure what's happening in real time or in the recent past, and then make sense of the policies that drive those outcomes? And if those aren't the outcomes that we want, how can we change policies to improve those outcomes?
Okay, so the Galveston County Appraisal District raised my parents' house by about 80%. Am I better off handling it myself or hiring somebody?
That's a good question. We only looked at HCAD. If you are a homeowner, I would say it depends on the value of your time.
Okay. In looking at this coronavirus, there's been all these models out there predicting what's going to happen. Can you contrast for us the difference between what you do with data analytics and these models that are trying to predict the future?
For sure. I think that modeling is exactly what you're saying. It's our best guess of what the future is going to look like. And we see it every day with weather. And especially here in Houston, we're always trying to predict the weather. And we want to know if it's raining and if it's going to flood, is the street that I'm going to be driving on going to flood? Should I not get in my car? Which ways can I go? And we know that type of prediction is really, really hard. It takes into account all different types of variables. And I think that looking at a public health pandemic like COVID-19 is very similar. There's so many different variables that are at play that it's hard to build a model that can tell us exactly what's going to happen in the future. And just as a kind of a glib example, there's a chance that when you walk outside every day that you're going to get struck by lightning. But that chance is so low that you're not scared about walking outside. But one can't say for certain that there's 100% chance that you're not going to get struck by lightning. And so it's all about the degrees and the ways in which models are interpreted and communicated. And ultimately what it leads to is that the general public needs to have better literacy when it comes to what's a projection and a best guess and what's actually happened in the past and is a real outcome.
And I guess the thing that I've struggled with a little bit, I've looked a lot at the IHME group's model out of Washington University, which is something that a lot of people have been following, is in the news a lot. And they have various parameters in that for different factors that will affect the virus's spread. And it's really hard to understand how you can reduce that to a mathematical equation. Like, for example, there's a parameter that says if we close non-essential businesses, we think it's going to reduce the infection rate by this amount. But of course, every state is different on what they call a non-essential business, how much that's actually enforced, to what degree people pay attention to it, to the essential businesses, do they social distance or not? I mean, I just can't imagine how you can build all that into a mathematical model. Your thoughts?
Well, I think that you're honing in exactly on the right things. Data is very precise, and these models will not be accurate at all unless that precision is carried through at every step of the analysis. And if we can't decide what's essential or what's not, or in the case of COVID-19 and incarcerated people, who's violent and nonviolent, that's not necessarily a designation in the law. The data is not going to necessarily tell us what violent versus nonviolent means, just as the data is not going to necessarily tell us what essential and non-essential means. And unless we have agreement on that across the whole board, then the models are going to be wrong. That's not to say that they're going to be so wrong that they can't be followed. You know, I can give you wrong directions to my house that'll still get you there, but it's really important to build public confidence in these projections. And so having agreement on what terminologies mean is extremely important. And I think that that's kind of one of those cornerstones of science that we're all starting to see.
I guess what we're all trying to figure out is are the models, to use your analogy, is going to get you to your house, or just going to tell you what state it's in? You know, what's the degree of variability there? I think that you've done a lot of work on this issue about looking at various health effects in Harris County itself. I know you participated in a study recently for the Harris Health System. And in that, what did you find, before we talk about COVID for a second, just tell some of the general conclusions that you all reached about the state of health in Harris County before the epidemic, and talk about the disparities a little bit.
For sure. So we did a lot of work with last year with Harris County Public Health, and they produced a really wonderful 250-page report called Harris Cares, and it looks at public health issues such as chronic disease or infectious disease throughout Harris County. And generally speaking, the correlations that we see in Harris County are similar to the correlations nationwide, in which those who have resources, access to resources, financial resources, generally have better health outcomes than those people who don't. So if you are wealthier, you generally have better health outcomes. If you have better health insurance, you generally have better health outcomes. And so when we start looking at issues of chronic disease, we can start to see that affects our Black and brown communities, and it also affects our low-income communities, and sometimes those overlap disproportionately, largely because of a variety of factors. You could look at things like diabetes or high blood pressure and say, well, maybe access to healthy foods in these neighborhoods is one of the driving factors of that. Maybe maybe it has other public health or cultural indicators that can give rise to those different outcomes. But what I think is really interesting is that there's a very clear correlation between if you have access to health resources, such as doctors and clinics, you're going to have better health outcomes. And I think from a public health perspective, it makes a lot of sense to invest in public health to prevent people having to go to the hospital. If you can create systemic change against diabetes and high blood pressure by having generations of people eat right and not have bad food in their body, or have them access to better health care, then you're going to prevent downstream people being in the hospital. And when they're in the hospital, they're very expensive. We take a lot of looks at the business case behind behavioral change or policy change to better say, when we're spending money downstream, we know how much that costs. How much would it cost to intervene upstream? And how can we experiment with that to try and figure out what are the right tools and tactics that are going to make a difference?
Okay, we got to hold it right there, Jeff. Just hang on a second. We're going to take a break and pay some bills. We're going to be right back in about 3 minutes. Listen, if you would like to call in and ask some questions about this topic, the number is 713-212-7950. 713-212-7950. We'll be back just after the break.
Houston, you need answers. Jesse Kelly has answers.
That's a fact.
Hello, this is Bill King. We're back with some common sense. We're talking to Jeff Reichman from January Advisors. Jeff, welcome back. Jeff, you know, we've been talking about this, your report that y'all did with Harris Health, where you looked at the incidence of certain types of chronic conditions like diabetes and obesity, and you've got some great maps in that report that show that. And I couldn't help but notice when I was looking at the maps of where the COVID fatalities come so far, they typically are coming from those same areas. Does that make sense to you?
I haven't looked at the numbers directly, but it does make sense because the areas that have the greatest health disparities are the areas that are most vulnerable to COVID in the first place.
And that's going to be pretty much true in any kind of disaster, right? I mean, it also is they were the hardest hit in Harvey, and if you don't have resources, you're not going to be as prepared to deal with these kind of onsets of disaster.
It's true, and even the Kinder Institute's most recent report on job losses from COVID so far are showing that our most vulnerable communities are the ones that are also hit the hardest.
Yeah, so I was going to ask you about that question. Have you started looking at the issue of what the economic impact is of the outbreak on Houston generally and on specifically lower-income neighborhoods?
Yeah, so, I follow what the GHP is looking at. They get really good numbers from the Texas Workforce Commission around unemployment filings. And I think that it's interesting to look at that economic impact because we're getting kind of a 1-2 punch between COVID and then the bottom falling out of the oil market. And no matter how bullish we are on oil and gas as a city, it still takes time to recover from this kind of volatility. It can take 4 or 5 quarters even just to find equilibrium again. And so I think that we are kind of in the middle of a tornado, and we need to figure out how we're going to adjust from this, because while we have already had a massive service economy hit from COVID, we're going to start to see some lingering effects from that, and we're going to see some layoffs from oil and gas, and that's going to reverberate into government. So government services are likely to be cut because sales tax is going to go down. And it's going to reverberate into housing as people who lose their jobs can't pay their mortgage or can't pay their rent and are likely to either get evicted or get foreclosed on. And that creates instability in some of our most stable markets. So I think it's important for us to take a long, hard look at the social implications and economic implications that are beginning to unfold due to this crisis, double whammied with the oil crisis.
Yeah, well, of course, you're not old enough to remember this, but I was here in the 80s and we had the oil crisis back then. And I remember we had a couple of years that Harris County's population actually declined. If you can imagine, that's unthinkable today. But I guess here's what I've struggled with, this whole idea of the models like the University of Washington model. They don't take into account at all what the cost of the various containment strategies are. They just say, look, if we do these things, it's going to result in this fewer cases. And that's kind of driving the policy right now. But how do we incorporate, how do we think about, here is the harm that's being done by these versus the harm that would be done if we didn't do anything. And I don't see that we've got a framework for thinking about those kind of decisions yet. What are your thoughts on that?
I agree with you. I'm not sure that we have a framework for that yet. And one of the biggest challenges that we face is that, Texas ranks 47th in testing. So we're not testing enough people in order to get that top of the funnel number, a universe of how prevalent COVID-19 is in our community. And we're fortunate that, our hospitals haven't been overrun, and we're fortunate that that it hasn't summed up to the worst possible predictions that are out there. But we do know that it's here. So there's some corroboration that this isn't a myth. But I think it would behoove us to have better testing and more coordinated testing across the state and across the country to better compare regions and understand which models apply to what regions, because Houston's different than Minneapolis, which is different than New York. And Bill, you and I have talked about the differences in culture between, say, New York and Houston versus getting on the subway versus getting in your car. And I think that it's really important to have a baseline standard of incidents per capita and then start to look at some of the cultural differences and the social differences that may lead to more transmission of the virus versus less transmission.
The testing question is really an interesting one. Frankly, what I would like to see is a lot more of the antibody testing like they did in New York and California, because that would give us a lot better population numbers. It's obviously not as valuable for therapeutic or clinical reasons, but if we really want to know how widespread it is, we need that antibody testing, and I don't see much of that being done at all so far.
Yeah, I haven't heard much about antibody testing. I know it's starting, but I certainly think that we need more science. We need to be able to get more information about this disease and learn more about it because it's out there in the wild. And if we can contain it, that's great. And if this is the worst of the economic impact, well, God, I hope so. But if we mess up and we get it wrong, then I think that there's no takebacks. So right now, I see policymakers erring on the side of caution, but I also think that some of the cautionary things that they're asking us to do are not a very big deal, like wearing a mask or washing our hands. And some of them, like shutting down businesses, are a very careful decision that, I'm sure that our policymakers agonize over because, you really you're damned if you do, damned if you don't. And if they get it wrong and they open up too soon and we see another outbreak, well, then those are potentially needless outbreaks. But if we don't open up and we wait too long, then ultimately we're economically injuring everybody. So I don't envy the people who have to make these decisions right now with science that is limited. And I think that overall, I'd like to see what happens over the course of this next week or two as Texas starts to slowly open up, because we're taking a big risk. And I hope that it's the right risk.
Well, that's what's so difficult about this is, we can't compare what would have happened in an alternate future. We don't know what would have happened had we not shut down the rodeo. We don't know what would happen had we not done this opening. And so we're really sort of guessing at what the effect of all these things are. And it's something that, frankly, I'm not sure we're ever really going to know the answer to.
Yeah, we won't, and because we only live on this one timeline. But I do think that if we look at phases of time as we study this disease, we will understand that if we opened up too early and we have a second outbreak, we can see some correlation there. Or if we don't have a second outbreak, then maybe we opened up at the right time, or maybe even too late. I think that the numbers have yet to come in. But what I think and what my company tries to concentrate on are kind of the social impact effects of this. Right now, we have an evictions moratorium. And so you can file eviction cases, but they won't be processed unless you're a threat to other tenants. And so what that means is that landlords still are able to collect rent and tenants still have to pay rent, but people aren't getting evicted yet. And with all of these job losses, it's going to be interesting to think about, like, if we have mass evictions, that's bad for landlords. That's very bad for landlords. That's bad for landlords who have to pay the banknotes. And that's bad for banks. So when we look at the whole housing supply chain, we have to say, what are the best policies that we can use to mitigate those unforeseen impacts of the recession that comes out of COVID-19? And I think right now we just have to minimize the harm that we do and try to make the best decisions guided by the best information at the time. And I really hope that's what we're doing.
Today, we're going to have to keep looking at this data. I think it'll be interesting to look at places like Georgia. They're being more aggressive compared to places that are being more conservative like California, and compare those. Although there are still so many other variables, it's really going to be hard to draw too many conclusions from that, I'm afraid.
It is, but I'm really glad that smart people are looking at this from all different perspectives and trying to make sense of it together as a community, because the best insights are going to come from all different perspectives, questioning the data and demanding more rigorous testing and demanding more rigorous analysis. That's what's going to get us out of this. Okay, great. Well, Jeff, I really appreciate you being here on the first show. I want to have you back for sure. Folks, I can't believe that an hour has already gone by. We could have talked to Jeff and to Dr. Hotez for a whole lot longer. But we're going to wrap it up here for today. I hope you found the discussion interesting and help you navigate these confusing and trying times that we live in. Next week, we're going to be talking about the future of mass transit with Metro Chair Karn Patman and Transportation Planner Ernie Gaddis. I hope you will join us then, May 9th at 2 p.m. right here on KPRC 950 AM.